Welcome to today's Satellite Symposium, supported by an educational grant from CSL Behring. Strategies to identify chronic antibody-mediated rejection before it's too late. Today's moderators are Carrie Shinstock and Molly McCarthy. Today's session speakers are Chris Wiebe from the University of Manitoba, Marta Crespo from Hospital del Mar, Barcelona, and Arjang Jamali from the University of Wisconsin. If you would like to submit a question directly to the session moderators, please utilize the Q&A feature on the side panel of your screen. Enjoy the session.
Okay, thank you for the opportunity to speak at this year's CIOT. I have no disclosures. I was asked to speak about de novo DSA and molecular mismatch, as well as non-adherence and immunosuppression. So I'll try to cover all those in 12 minutes. I'm going to start by pointing out that we believe de novo DSA to be important because of its strong association with both antibody-mediated rejection and graft loss. We know that there are many risk factors that have been reported, and some of the most consistently reported are younger recipient age, probably because of a more robust immune system, inadequate immunosuppression, HLA mismatch, and preceding T-cell mediated rejection. I'm going to start by talking about HLA mismatch. As many of you are aware, right now, if we had a recipient who's a DQ8 shown on the left, and we were to expose that recipient to either a DQ5 on the top or a DQ9 on the bottom, each of these scenarios would be considered a one antigen mismatch, the way we talk about things today. However, many of you are also aware that if we actually look at these molecules at the molecular level, we can quickly see that some molecules have very similar amino acid sequences, whereas others are quite different. And one way to talk about this and quantify it was developed by René Duquesnoy, where he said, well, we can identify where these polymorphic amino acids are on the molecular surface, and we can therefore identify and define small clusters of amino acids that he called eplets. And those small clusters roughly correspond with the binding surface area of a single complementary determining region on an antibody. So this can be thought of, these eplets, as the smallest functional unit of an entire epitope. Now, if we bring this example back and we look at the eplet mismatches, we can see that the DQ5 example on the top actually has 27 eplet mismatches, whereas the donor on the bottom, the DQ9, only has 2 eplet mismatches. So this is a 13-fold difference in the amount of non-self tissue being exposed to the immune system purely by chance, depending on which of these two donor scenarios you chose. And there's really no reason to believe that the immune system would consider these both equal. So if we actually look at some raw data, this is over 4,000 molecules that we quantified the eplet mismatch. Each of these represents a one mismatch for either DR beta 1, DR beta 345, or DQ alpha beta. You can right away see how much heterogeneity there is within single molecule mismatches. And you can also see right away why we likely see more DQ de novo DSA compared to DR de novo DSA, because there's a lot of high DQ mismatches here. Now, we use this raw data in conjunction with our post-transplant DSA monitoring results to say, well, we knew what the mismatches were, who actually developed an antibody post-transplant. And of course, because we have single antigen bead assays, we can do this. And we used these scores to actually develop a risk categorization system where patients were categorized as low, intermediate, or high risk for developing de novo DSA against either a DR or a DQ molecule. And you can see that this was highly statistically significant. We also applied this score to ABMR and TCMR. And in all three situations, this low, intermediate, and high alloimmune risk categorization were independent multivariate predictors of these outcomes. This data has since been validated in a few centers. This is one example from a group in Denver, Colorado. You can see that in Denver and in Manitoba, the majority of the patients were Caucasian. However, in our group in Manitoba, if you weren't Caucasian, you were most likely Indigenous or Asian, whereas in Denver, you were most likely African American or Hispanic. Nevertheless, the Denver group was able to reproduce our exact same thresholds that we used in the risk categorization system with very nice AUCs. And just like we showed in their multivariate model, they also showed that the autoimmune risk categories were very strong multivariate predictors of de novo DSA free survival, even after adjusting for tacrolimus and other factors. Lastly, here's a third study by the Senev et al. Group in the Netherlands, where they, again, had a low prevalence of de novo DSA, likely because their cohort was very well matched. But if you look into the supplementary figures, you see this figure here on the right, where they used our low, intermediate, and high risk categorization. And again, they saw a layering of the risk with a more than 7-fold difference between low and high risk. So let's switch to immunosuppression and see how these two risk factors might interact. Way back in 2015, we did a study. It was actually a non-adherence study as well, with Tom Nevins and his group in Minneapolis. And they had a lot of data about the adherence of their patients because they had been using these MEMS medication adherence caps that have a chip in the cap of the bottle so that you know when the patient opens them. And we showed in this cohort very early on that the patients who had the greatest rejection and allograft loss were those that had both non-adherent behavior and a high uplet mismatch. We then went and looked in detail at our own cohort, looking at over 50,000 tacrolimus levels in about 600 patients, so almost 100 levels per patient on average. And what we showed is that if you were high risk for de novo DSA, that those who had the greatest percentage of tacrolimus levels below target were the ones that went on to make the antibody. And that was probably no surprise. What was very interesting, though, is we also had this low-risk cohort that had low eplet mismatches. And we found that those patients never developed de novo DSA, even though their tacrolimus levels were just as frequently below target, or maybe even more frequent. So this suggested to us that the molecular mismatch seems to be modulating the need for tacrolimus in these patients. Again, some earlier data from the Denver group again showed that if you look at the mean tacrolimus level in the first year, the lower the mean was, the higher the risk of developing de novo DSA. And they also looked at kind of an area under the curve tacrolimus level and showed a correlation with that as well. So those are some retrospective observational studies. I'm going to also show 3 different prospective randomized studies. This was a study done by a French group where they took patients and for 3 months, they followed them closely, made sure they were doing well with no rejections, and then they randomized them to either a low-dose tacrolimus arm or continuous standard of care arm on the right. You can see the low-dose arm had tacrolimus levels just over 5, whereas the standard of care was in the 7 to 8 range. And by 1 year, they already showed a statistically higher incidence of rejection, de novo DSA, and I-score on protocol biopsies at 1 year. In a second randomized study by a separate French group in Renaud Sanuj, who's a friend of mine and has looked into eplet mismatch in their cohort, they again did a 3-month randomization to either continue on cyclosporin or switch to everolimus. And clearly they saw an increased rate of de novo DSA in the everolimus arm. But interestingly, in a multivariate analysis, when they actually did the eplet mismatch in this cohort, they found that the eplet mismatch was the strongest multivariate predictor of who in this everolimus arm actually went on to develop de novo DSA. And lastly, a trial that many of you are familiar with, the CTOT-09 study, which really tried to do everything they could to select low-risk patients for tacrolimus withdrawal. They selected living donors only who had low PRA. By chance, they happened to be mostly Caucasian due to the centers they were examining. They all received thymotacrolimus, mycophenolate, and prednisone. They all had stable 6-month course with no rejection on a 6-month biopsy and no DSA by repeat antibody screening at 6 months by single antigen bead. Nevertheless, when they started to withdraw tacrolimus, they saw that they had a higher than expected incidence of both rejection and de novo DSA, leading to an early halt of this study. What we learned retrospectively when we looked at the eplet mismatch is that all of the patients who developed de novo DSA against DQ had high DQ eplet mismatches. And in fact, even a few of the patients on this side, one of them developed a DQ almost immediately after the trial was stopped. The second patient circled in blue developed a TCMR and therefore was put back on their tacrolimus. And so even in only 21 patients randomized, we're already seeing a statistical correlation that was significant, suggesting to us this is a more precise way of looking at mismatch compared to our traditional antigen-based approach, where we often need hundreds or even thousands and tens of thousands of patients to show a statistical relationship with outcomes. Lastly, I'll just highlight that there were some patients who had low uplink mismatches and actually tolerated coming off of tacrolimus. So in this short talk, the take-home points that I hope came across were that number one, inadequate immunosuppression, either through non-adherence, through minimization, or other means, can lead to de novo DSA in stable patients, indicating that immune quiescence or stability does not equate with low risk. And in fact, as I showed from the CTOT-09 study, we traditionally are not very good at identifying who's low risk. HLA molecular mismatch may serve as a predictive biomarker for primary alloimmunity. So this is, in other words, predicting who's going to have an alloimmune reaction, excluding patients with alloimmune memory. We know that those who are low molecular mismatch may tolerate less immunosuppression. And if we were going to study this again in a either withdrawal study or minimization study, I think this would be the group you'd want to examine. But just as important, those with high molecular mismatch may help us to enrich clinical trials to test novel immunosuppression augmentation strategies. Let's say we wanted to study rejection and a novel agent. Well, we'd likely want to select for the high-risk patients that we know are at risk of having these events, and that would prevent us from immunosuppressing people at greater levels that really won't benefit from it. I'd like to say thank you to the many people that have collaborated with us and funding sources. Thank you.
Good afternoon. I'm here to share some thoughts about a practical approach to DSA monitoring for surveillance and indication. I have no conflicts of interest, and I will follow this agenda. We will have the opportunity to speak a bit about the advantages of HLA DSA monitoring, then the limitations of post-transplant monitoring, and finally, when it is appropriate to test for HLA DSA for indication or surveillance. Regarding the advantages of DSA monitoring, we know that the interaction between donor and recipient happens at the endothelium level. There, the immune cells of the recipient may recognize molecules that are exposed on the surface of the endothelium or molecules that exist beneath the endothelium but become exposed because of some damage of the endothelium. And therefore, this interaction can induce the production of HLA donor-specific antibodies and maybe the occurrence of antibody-mediated rejection. And the most frequent antigen involved in this response is the HLA or are the HLA antigens. And detection of antibodies against HLA antigens of the donor can be performed with different techniques. There has been a great progress in the technical sensitivity of this test. We were working with cell-based assays for a long time with CDC or flow, but for the last 15 years, we have become used to employ immunoassays, solid phase assays based on the use of beads with verified and HLA antigens on the surface. And these techniques are less specific, but more sensitive than the previous ones. And several studies performed with these sensitive techniques have helped us to understand that the detection of HLA DSA with these techniques, but not with the old ones, are a risk factor for graft survival when we detect them at the time of transplant, but also after transplantation at any time post-transplant. So we know the utility of detecting HLA DSA at transplant and at any moment post-transplant. But is there any advantage of surveillance testing, instead of testing just once in the life of the patient, does it make sense that we do post-transplant monitoring at different times? Here, I'm sharing with you this kind of old study from 2013, one of the earliest studies with these new Luminex techniques. In this study, they monitor 189 patients at different time points post-transplant during the first year and then yearly, and they found that at 5 years, 20% of this cohort so HLA donor-specific antibodies, and half of them had developed these antibodies within the first year after transplantation. Most of the antibodies were directed against a DQ mismatch antigen. And the existence of those antibodies at year 1 these antibodies, at any time, associated with a 9% risk of fail 1 year after the detection, or 24% 3 years after the detection of antibodies. So it looks that it makes sense to have systematic monitoring. This interesting study from the groups of Paris so that when they reviewed the existence of de novo HLA donor-specific antibodies in a cohort of 850 kidney transplant recipients that were monitored or were studied either at dysfunction or 1 and 2 years after transplantation, they found that 186 patients had HLA donor-specific antibodies de novo. 86 patients at a point where they showed some dysfunction, 55 patients at the time 1 year after transplantation, and 45 2 years after transplantation. And if we go and look at the biopsies that they perform in those patients, 75% of those with DSA detected at dysfunction showed antibody-mediated rejection, but also 75% of those tested for surveillance at 1 year, and 58% of them tested for surveillance at 2 years. So clearly there's a relationship between detection of donor-specific antibodies and antibody-mediated rejection that we might have missed if we had not done either surveillance for HLA-DSA or surveillance biopsy. What happens to those patients with preformed donor-specific antibodies? Is there any different impact if they have preformed antibodies that persist after transplant or clear after transplant? In this study from the group of Martin Nassens in Belgium, they monitor patients at biopsy, but then at different time points, and yearly after kidney transplantation. So those were HLA antibodies studies for indication and for surveillance. And they saw that those patients with preformed antibodies which persisted after transplantation had worse graft survivals than those patients with preformed antibodies that resolved after transplantation. So it is really useful to know what happens to the preformed antibody after the transplant. For that, you need to test those patients after transplantation. We found similar data in a study from our group. We also found that we had transplanted 11% of patients with a non-preformed donor-specific antibodies, and we found that those with persistent antibodies had a lower antibody-mediated rejection-free survival. That's to say, more frequently antibody-mediated rejection when they had persistent compared when they clear their performed antibodies. And interestingly, those with the higher incidence of antibody-mediated rejection were those patients with de novo HLA donor-specific antibodies that were detected for surveillance. And is there any need to have DSA testing when you already have a biopsy? So if we have a biopsy, Do we still need to invest in testing our patients for HLA antibodies? Here is a study from the group of Belgium, of Leuven, where they studied over 200 kidney transplant patients who had a biopsy which looked like antibody-mediated rejection. 40% of them had no HLA donor-specific antibodies at the time of this biopsy, and 60% of them did not have. 40% of them had HLA-DSA, 60% of them did not have HLA-DSA. And here, when we look at graft survival, we see that those patients with antibody-mediated rejection with HLA-DSA had worse graft survival compared with a similar biopsy without HLA-DSA. Our group has performed a similar comparison, and here, out of 186 patients with a biopsy compatible with antibody-mediated rejection, those with HLA-DSA, that is with full ABMR, had worse graft survival compared with those who had microvascular inflammation without HLA-DSA. And that happened when this microvascular inflammation was only active, and microvascular inflammation, active antibody-mediated rejection. So microvascular inflammation without HLA-DSA compared with active ABMR or chronic ABMR. So the existence of HLA-DSA made the difference in terms of graft survivals for those patients. And of course, we have limitations for post-transplant monitoring, and I will mention some of them. First of all, let's go to some technical issues. We have to decide what's the strategy that we are using to monitor our patients. And here I'm sharing with you one of our studies where we tested 118 kidney transplant recipients at the time of biopsy after transplantation with two parallel strategies. The first strategy is based on using a screening test first and only using single antigen B tests for those who screened positive. Strategy 2 consisted in using directly single antibody B tests for all patients. Here is what we found in terms of results. When we tested 19 patients with a normal biopsy, 52 with ABMR-like histology, and 47 with interstitial fibrosis and tubular atrophy, we found with the screening strategy that only 61.5% of our patients had with ABMR histology had HLA donor-specific antibodies, and 8% of those with interstitial fibrosis and tubular atrophy. But when we tested all those patients directly with single antibody tests, antibody B tests, we found that almost 80% of our patients with antibody-mediated rejection like histology had HLA donor-specific antibodies, but also some patients in the normal group and in the interstitial fibrosis and tubular atrophy. It means that the most sensitive test added 13 kidney transplant patients with DSA at the time of biopsy. 1 in the normal group, 3 in the interstitial fibrosis and tubular atrophy group, and 9 in the group which showed a biopsy which looked like antibody-mediated rejection. So to test directly with single antibody tests is useful, apparently, according to our data. Then we found, as I showed you, that 13 patients had different results comparing the two strategies. And we decided to compare the results of employing single antigen beads from the two different vendors to study these 13 patients with discordant results. When we applied single antibody testing from one company and the other company, we found that half of them were concordant and they have HLA-DSA with the two vendors, with tests from the two vendors, but 7 of them had HLA-DSA with one vendor, but not with the other. And even for those who were concordant or who saw concordant results, the MFI results, etc., were not the same. So we have to have in mind that it is not the same using different strategies or using different vendors, which may be more or less sensitive for some HLA antigens or others. And that there is another aspect that is interesting, and it is the cost of the strategy employed. And here I'm showing the difference in using in our study the first strategy, screening and only single antigen beads if a screen was positive, or direct single antigen beads. And the difference was around 4,000 euros in our context in Spain. And that was the difference in testing 118 kidney transplant recipients and only one sample. So we need to have in mind these numbers and to think of the number of patients we want to monitor, and if we want to do it yearly or every 6 months or whatever. And here, as a limitation, I have to highlight too, that is to be able to interpret the result of the HLA-DSA test, we need to have good information on the HLA genotyping of the donor. So if we have only low resolution compared to high resolution HLA typing of the donor, it can have important influence on the concordance or discordance of assigning a specificity. And in this group from Leuven, again, we can see that using a higher degree of resolution, or the information from a high resolution typing, is associated with a better assignment of HLA-DSA as they are associated with worse graft survival. And this wrong assignment, because of not having a high resolution typing of the donor, was mainly or more important when the discordance was related to the HLA-DQ antigen of the donor. So it is important that we monitor, but we need to have the information for the full information to make the best interpretation. And last but not least is the fact that there is not a strong evidence to treat our patient. And until now, we have a low degree or low evidence information regarding the decision of treating a patient with antibody-mediated rejection and donor-specific candidates. So to finalize, we have to speak about when it is appropriate to test for DSA for indication or surveillance, when and how often. This is not an easy task. In fact, the STAR group of experts in immunology and transplantation who have elaborated two guidelines or recommendations regarding monitoring of HLA donor-specific antibodies in transplant recipients 4 years ago said that the lack of high-quality evidence precludes us from making any specific recommendations as to the frequency and duration. At this point, it should be a program-specific decision. And in fact, they suggested that depending on the organ that we were speaking about, lungs, hearts, or kidneys, we have to decide at when and how often monitor for HLA-DSA. In this next slide, I want to show to you a study that we performed in Spain, and the recommendations that came out from our study based on expert opinion and the review of the literature. And I have summarized here what I think may be of help, and it is similar to what the STAR group was recommending in the previous slide. When to test for HLA-DSA, we have to establish the risk at transplant and decide how often this patient will need a test, because it is not the same to have a low immunological risk patient or a high risk patient. At least one test should be performed in the first year, earlier in those high risk patients compared to the low risk patient. As you can see, low risk screening every 2 to 24 months after transplant. If medium to high risk, one single antibody test every 12 months. At dysfunction, non-adherence, or biopsy, we have to test for HLA donor-specific antibodies. And if one patient develops de novo HLA donor-specific antibodies, then we have to increase the frequency of testing. So I hope that this interests you and that we can have some discussion and see if you agree or not with all these thoughts. Thank you for your attention.
Ladies and gentlemen, hello. I would like to thank the American Society of Transplantation, the organizers, and the chairs of this session for inviting me to talk to you today about de novo DSA, entitled "My Patient Has de novo DSA, Now What?" This is my disclosure slide. And I would like to start with a patient perspective and vision statement. That is the picture of Mary Balliker, who was my patient in Wisconsin. Mary is an author, a healthcare consultant, and also a 4-time kidney transplant recipient. For Mary, the ideal scenario is 1 kidney for life, optimal immunosuppression where there is no cancer, no rejection, no infection, and no biopsy. Totally understandable, and I consider this as my true north as a healthcare provider. So what is de novo DSA? I will primarily focus on a clinical and practical approach. The definition of de novo DSA focuses on antibodies that do not pre-exist, that is, not a memory response, but develop after transplantation, and are directed against HLA antigens primarily or other antigens. The prevalence of de novo DSA varies based on the study and based on the location and based on definitions. But as you see here, anywhere between 10 to 40% prevalence has been reported in the first 10 years after transplantation. As I mentioned, the reasons for variability are numerous, but primarily focusing on differences in regional and transplant populations, including high versus low immunological risk, the lack of standardization across single antigen bead kits and HLA laboratories. For instance, a low titer DSA, if in the presence of an antibody epitope that's spread across beads, could be undetected. MFI cutoffs, a high cutoff for a lab could miss a low titer DSA, and the historical serum, for instance, if historical sera are not available and might have been positive, in that case, the DSA could go unnoted. But the question is de novo DSA bad? And the answer is, well, generally yes. And it is not a new concept. This study was published by the Manchester team in the United Kingdom about 35 years ago, in which the investigators demonstrated that patients that had a PRA that was negative at the time of transplant but became positive at the end of transplant, the bar graph, the red bar graph on the right side, had the worst 1-year outcome. And in fact, 26 of 28 of them ended up having detectable de novo DSA based on cell-based assays. The Manitoba team confirmed this, as well as many other teams, that the presence of de novo DSA is associated with poor long-term outcomes. And this is a 10+ year follow-up after transplant. And this is bad, especially because once patients return on dialysis, then their mortality rate is more than 3 times greater than those that stay with a functional kidney transplant. So is this an association or a causation? Should I biopsy after detecting de novo DSA, and should I monitor them? Well, the answer is yes, and this is the consensus guidelines based on testing of de novo DSA or DSA after transplantation. The guidelines were published in 2013, were highly valuable from my perspective, and the proposal was to risk stratify patients in 4 groups: very high risk, intermediate risk, and low risk, and customize a monitoring strategy for HLA DSA measurement, in which whenever there is a positive DSA, a biopsy should be performed. But we all know that the kidney allograft biopsy is an invasive procedure, has some sensitivity and specificity limitations, at least based on BANF. There is inter and intra-observer variability, and there's also a question of reproducibility. Nevertheless, it turns out that not all de novo DSA are bad. For instance, this is a study by the Mayo Clinic in which the definition of de novo DSA was based on an MFI of greater than 1,000. And 54 patients out of 700 plus developed de novo DSA, underwent a protocol biopsy, but only 32% of them had rejection. When the biopsy was repeated at 1 year, then the sensitivity, the positive predictive value was greater at 91%, but nevertheless, the first biopsy time had a lower positive predictive value. This was confirmed by an Austrian study, a multi-center study, in which the positive predictive value of de novo DSA for antibody-mediated rejection was 51%. Similarly, in a multi-center study from the US, published recently by Stan Jordan and group, demonstrated that the positive predictive value of DSA for the diagnosis of antibody-mediated rejection was around 48%. The Wisconsin team, when I was there, we also looked at this question and demonstrated that if the de novo DSA definition was based on an MFI of 300, then the positive predictive value for a biopsy to demonstrate antibody-mediated rejection was again 50%, 48%. And interestingly, when these patients were followed over 5 years, they did not show worse graft outcomes compared to the others. So the summary of this is that not all de novo DSA are bad. How can we enhance the positive predictive value of de novo DSA? Well, it turns out that the addition of some of the newer biomarkers, such as donor-derived cell-free DNA, can help with that. This is a study published by Stan Jordan and his team looking at the combination of AlloSure measurements with de novo DSA, in demonstrating in the orange panel here that if the cutoff for donor-derived cell-free DNA was at 1%, the positive predictive value of combined DSA and AlloSure was at 81% for rejection. And if the cutoff for AlloSure was at 2.9%, then the positive predictive value for rejection increased to 89%. So there is a role, there's a potential role for multimodality testing to enhance the positive predictive value of HLA DSA for rejection. But biomarkers have definitely advantages. They are non-invasive, they enhance diagnosis accuracy, allow prospective monitoring, and make it possible for multimodality testing. Nevertheless, there are other limitations, including time dependency after transplantation, and they need to be validated in prospective interventional randomized trials, and they are costly. So how can I treat DSA, or should I treat DSA in the absence of rejection? Well, this was only studied by one group that was published based on my knowledge. This is Mary Matignon and her group in France looked at a group of about 20 patients that had no evidence of rejection at the time of biopsy. Half of them received a high-dose IVIG for 12 months and the other half did not. And it was determined that the incidence of rejection at 12 months was no different, suggesting that high-dose IVIG is not effective in preventing ABMR in patients that have evidence of de novo DSA without rejection. Then, let's say my patient has clearly antibody-mediated rejection. What should I do? In that case, I'm just reporting here the evidence described by the consensus guidelines from the Transplant Society here, and according to this report, in terms of chronic antibody-mediated rejection, as you can see here in the green box and in the blue box, all we can do is to optimize a baseline immunosuppression. For instance, add steroids if on a steroid-free regimen, and adjust the calcineurin inhibitor dose, etc. Otherwise, IVIG may be considered as an adjunctive therapy, but no real other benefit from previous studies has been demonstrated. I will focus on two randomized clinical trials. This is the first one for the treatment of antibody-mediated rejection with imlifidase, and this is early after transplant, and the two arms are imlifidase, IVIG and rituximab compared to plasma exchange, IVIG and rituximab in a 2-to-1 ratio, with an endpoint being a DSA decline after 5 days of therapy. It's a small study, it's phase 2, but it's an important study, so please, if you are a center that is involved with this, enroll patients. The second study is the single largest randomized multicenter placebo-controlled clinical trial for the treatment of chronic active antibody-mediated rejection with IL-6 blockade, and that is clazakizumab. Half of the patients receive IL-6 blockade and the other half placebo. The study is ongoing, and again, if you are part of this study, please enroll patients, because this is extremely important for us to answer the question of whether there is a treatment for antibody-mediated rejection or not. So in summary, my patient has de novo DSA. Now what? I would say after the determination of de novo DSA, consider whether you want to do additional biomarkers to enhance specificity, to do the biopsy or not. You conduct your biopsy, and that biopsy demonstrates rejection. If it demonstrates rejection on the left side, well, ideally you would enroll the patient in a trial, and then if not, you can treat the patient based on your standard of therapy. In the absence of rejection after biopsy, the recommendation is do not reduce immunosuppression and monitor patients' kidney function and do the medical management that is appropriate for that level of care. And same if you decided not to biopsy the patient and monitor them, make sure that you are not reducing immunosuppression in the presence of de novo DSA. On that note, this is my summary slide. I would like to mention that we addressed the question that de novo DSA in general is associated with poor outcomes, but not all of them are bad. And novel diagnostic tools can help with a positive predictive value, but cost and value have to be considered. And finally, it's critical to enroll patients in clinical trials to optimize monitoring kidney function, baseline immunosuppression, and overall medical management of these patients. I always think of Mary and the fact that our goal is to keep one kidney for life, optimize immunosuppression, and avoid biopsies if possible. On that note, I'd like to thank you all, and I am grateful for your time and attention.
So I want to thank all of the speakers for their fantastic talks. That was great. And I want to remind the audience to participate in the panel discussion. Please submit your questions in the Q&A tab next to the chat tab on the left-hand side of your screen. So I'm going to start. There's a couple questions about whether this eplet match basing or this eplet-based matching strategy can be used in other organ groups. Chris, could you comment on that?
Sure, yeah, good question. As you may know, the eplet matching is based on our traditional matching, so there's really no reason that it can't be used. It's taking existing information that we have and just trying to make it more precise by looking at it at the molecular level versus the antigen level. So it's probably applicable across all the different organs that we transplant. Of course, those we might not get the same results, since some organ transplants are more immunogenic and some are less, but it should be applicable and usable across all organs.
Great, thank you. Are these findings applicable to OLT recipients as well? And related, does the type of IS affect DSA formation, specifically calling out CNI versus mTOR?
Yeah, I guess that's maybe directed at me again. I would say that we have a little bit of evidence that maybe I showed that one trial from the French group showing that there was a higher incidence of de novo DSA after randomization to everolimus versus staying on cyclosporin. I think we have evidence from both other trials as well as our own retrospective data to say that patients on cyclosporin definitely have a higher incidence of de novo DSA compared to patients on tacrolimus. And I think in general, the potency of immunosuppression is just associated with de novo DSA. So the less potent the immunosuppression, the more likely de novo DSA can develop post-transplant.
So we have another question. What are your thoughts about belatacept and DSA? And this, I guess, could be Dr. Jamali or Dr. Crespo. Any comments on belatacept and de novo DSA?
Martha, go ahead.
No, you're more familiar with belatacept than I am.
Okay. Well, there is some evidence that belatacept prevents the incidence of de novo DSA, and that is based on the BENEFIT trial and BENEFIT EXT trial, in which patients that were randomized to belatacept had a lower incidence of DSA. But that was not an endpoint that was really part of the study to specifically examine. And there's also evidence from Stuart Knechtley's group that the combination of belatacept with the proteasome inhibitors can be used for either desensitization strategies or treatment of antibody-mediated rejection. So it is understandable that co-stimulation blockade, as it is upstream from the antibody-mediated process, can be used and successful, but we need really randomized studies to determine that.
Thank you. As a patient, one of the things that grabbed my attention was the potential differences in the lab results based on the lab that was actually running the test. That's a little bit scary. Do you have any thoughts or any counsel that you might provide to the patient population in how to address that and think about the result and what the next steps might be? And I will leave it to the dealer's choice as to who wants to tackle that one. Thank you.
We are speaking about HLA donor-specific antibodies. As I mentioned in my talk and in my slides, you have to know which technique they are using, with what kind of test they are using, and which vendor. So sometimes the difference is due to the different vendor. It is not that they are not performing well. It depends on what you are working with. And so you have, if you mean that they are in one lab telling you that you have a DSA and another lab is telling you that you don't have a DSA, we have to have the whole information and really analyze it and know what's the HLA genotyping of your donor. If we have a full HLA typing and we can understand all the information coming from the antibody testing or not, or if we are assuming some of the information because you were transplanted a long time ago and the donor typing was low resolution or serological or whatever. So there are a lot of factors that may influence the result that one lab or one moment in life can give you or not. I don't know if any one of you wants to add something else.
Yeah, I think that's right, Molly. And in case there are other patients listening, I think you should always ask. If you're told two different things by two different centers or labs, you should advocate for yourself and ask somebody to explain it to you, because there likely is a explainable explanation in most cases.
Yeah, and doesn't it kind of depend on what the typing of the donor is? So I think the different vendors have different, um, different beads. And so I know at our center, if we find that a particular bead panel is, or we have it, particularly a patient with different ethnicity, not necessarily Caucasian, for example, that the different vendors have different beads. And so we would pay attention to what the donor's HLA typing was from a molecular standpoint. I have a question to Chris again about this eplet mismatch, because I think it's great that we're moving in this direction of trying to prevent DSA before it happens, given the poor outcomes. And one is how, what's your perspective on integrating that into allocation systems, particularly focusing on, could that lead to disparities for ethnic populations?
Yeah, good question. Number one is I think it's still a little premature to consider eplet mismatch in allocation, just because almost all the data that we have about how well eplet mismatch performs is retrospective observational data. And so I think, like everything, it needs to be proven in a prospective trial. And I can tell you those efforts are ongoing, and we hope we're moving in that direction very soon. I think probably the best place to start, and there's been a lot of interest for this in Canada, is with the pediatric population, because this is a small group of patients. Prioritizing those patients for really excellent matched organs wouldn't affect the donor pool that much, and it would probably be worth even shipping organs across provinces in Canada or states in the US in order to make sure that those pediatric recipients get a very well matched kidney that can last them for many decades, especially known that that besides eplet mismatch, some of the other strongest risk factors are younger recipient age and non-adherence, which both apply to that population. I think the ethnicity question is important and it needs to be considered, but in my opinion, those types of things can be accounted for in a scoring system. So if you knew that your eplet mismatch we're going to give you so many points towards allocation, but your study showed that you might disadvantage somebody, well, you can just add the points. These are point scoring systems, so those things can always be adjusted for as long as you've factored it into your score a priori.
Thank you. Any other comments on that before we go to the next one? Okay. Next question. In my experience, screening reagents for detecting HLA antibodies are extremely insensitive for detection of HLA DQ DSA. Using this approach, DQ DSA might not be detected in a timely manner. And the question is whether anyone has looked into this. Any specific initial answer?
I don't really know how to answer that, but I think it's, again, getting back to your question, Molly, and that's the variability of DSA tests reports from laboratory to laboratory and region to region. And Dr. ZB has a very nice comment in the chat box that I'll let you guys read later. But definitely, there may be other opportunities as well with some of the newer biomarkers to try to determine the biological relevance of these tests, but I don't have a good answer.
I think for Dr. Jamali, this is probably a question for you. It says, what is your approach to those patients who receive all the possible treatments for chronic active ABMR, but continue to have rising DSA? Do you enroll them in trials or just say enough is enough and relist them? What's your opinion? And others can answer as well.
Sure, thank you. Well, I will say that at the beginning when we were in Wisconsin, we would stick with our own protocols, and that was very similar to what is described here: plasma exchange, IVIG, and Rituxan. And then some would respond, or some wouldn't. And after failure, we would enroll them in the clinical trial if they met the inclusion criteria. And that's a big if, and many of them did. But as we progressed, we understood that probably a better option would have been to enroll them earlier in the clinical trial, because our standard of care is not necessarily the ideal situation, as we just talked about the consensus conference's recommendation. So my suggestion is, yes, if the patient is meeting still the inclusion criteria for one of those clinical trials, especially Imagine, I would recommend it.
And if I could add something to that as well, that I would probably avoid adding all of this additional treatment that hasn't been proven effective, because it has its own toxicities, and you are probably, if that patient needs another transplant, you might be putting them in a worse position for infections or complications after their next transplant. So, I mean, I would just be careful at throwing so much at the patient that might be futile, because you could be hurting them in the long run.
And let me
Yeah, Marta.
add one thing. Yeah, and I think we are not treating DSA. We are treating a patient with a graft function or dysfunction. So we have to evaluate many things and all the comorbidities and complications associated with treatment. So sometimes we have the feeling that there is no influence on the MFI of the DSA. And as we have had the possibility to discuss these days, maybe we are doing something with some treatments. And if the graft function is stable and the patient is tolerating, maybe we can use those drugs with common sense. So we have to individualize the treatment when we feel that we are not having like a rapid response in DSA, because it is not only that.
So this is another question I think that would be for Dr. Jamali and Dr. Crespo. The consensus conference on when and how to monitor for DSA and how frequently was based on assigning patients to high, intermediate, and low risk groups. But that was before data was available that reclassified patients according to epaulette mismatches. So how do your current practices reflect the classification with regards to frequency of monitoring treatment, immunosuppression, withdrawal, et cetera? And they mention, I imagine some patients would move from one category to another based on their epaulette matching. So essentially, how would you change your monitoring based on their epaulette mismatch?
We unfortunately don't have the bandwidth to do epaulette matching, so that resolves that question for us. But if we could, we would definitely move it forward in that direction.
I can say the same. We have performed epaulette mismatch for a research study, but we do not have like the 0.3 epaulette mismatch for this patient is 9 or 15 in DQ or in DR beta 1 or whatever. So we don't have that information yet. We are doing it for some patients before transplantation when we have a living donor and we have some HLA antibodies that are not DSA, and we want to decide if we are using thymo or not. We don't use thymo so often in Spain as you use in the US. So epaulette mismatch is sometimes very useful because it helps you to stratify at that point. But we don't have it for everyone yet.
Chris, it sounds like you do more of this in Canada. Can you speak on that?
Yes, we do the epaulette mismatch on every patient at the time of transplant. And like Marta suggested, we also use that information as part of our decision making on what type or any induction therapy to give. At this point, we haven't specifically changed our monitoring strategies based on the eplet mismatch, in part likely because this is a research tool, and we're very interested in acquiring the data to build up the idea that we can do this differently in the future. But it also, I guess, in part because we're waiting for that prospective data to say that this strategy is one that we should employ across the board. So right now we still monitor everyone the same. But yeah, we are doing eplet mismatch on all patients at the time of transplant.
I think that it wasn't so much brought up in these talks, but now there are a lot of new tools with kidney pair donation, for example, where you're able to do some more eplet matching or even HLA matching. I mean, we talk about eplet matching, but there's still value if you can do class 2 matching. From the panel, any thoughts about how you integrate those strategies in a kidney pair donation program? Which patients, when, how long in KPD, those kind of issues?
I can tell you in Canada, it's not integrated into the national program, but when we get local offers, we look at it, and we can see, obviously, when we have a living donor and we have more than one donor, we do use the eplet mismatch to help us risk stratify which donor we think might be the best option. And in KPD, obviously, these people are having a lot more difficulty finding a donor. So I think most of the time we're just happy when they've matched with somebody. And of course, we want to know what the eplet mismatch is, but we wouldn't usually use that information to turn down somebody who's had trouble finding a donor in the first place.
Yeah, we haven't used it for the pair donation program yet, but we have the opportunity to enter pairs to increase their matching. So it is something that we can consider. Of course, most pairs enter for incompatibilities more than for getting a better match.
Mm-hmm. I know, though, we're beginning to think about this more and adding these patients who would otherwise be compatible into kidney pair donation programs just for this, particularly for the young patients, pediatric patients. And I think it's not only really good for them to prevent rejection, but for a pediatric patient who might need a transplant later on, it can prevent sensitization and help them get a transplant. I think that's something in Canada you've mentioned. I think Molly has another question.
I do, thank you. And it's with a pretty significant dose of humility that I find myself in conversations like this. I definitely need an MD to follow a lot of the science. However, I do have at least some life degree, I think, after having 3 kidney transplants at 3 different centers. And it's a real privilege to hear things like this. And, I remember my own experiences of having DSAs tested and what a comfort that is to me, because I love just seeing that it's a negative result. That feels good. The question I have, though, and that I keep coming back to is, had I not had the good privilege of meeting folks like yourselves, I wouldn't know kind of the behind the scenes kind of curtain of, gosh, one lab might come up with a different result than another one. And some centers have some practices and cultures, I think, of different testing than other centers. And I can't help but feel some level of concern of those of us who don't have the weary wisdom of 31 years post-op. How do we know that? So how do we advocate for each other as a patient community to know what questions to ask and to know what tests that we should be asking for, just to ensure that, we're taking advantage of the science and the innovation at the same rate, regardless of which center we might be at? And I will let you all decide who wants to tackle that one.
I think that's my recommendation, is that you have a direct talk with your doctor. I mean, I don't like that the patient comes to the outpatient clinic and receives results only, but engage into conversation and understand what's happening. Because sometimes some results can be just a mark or a biomarker that may mean something in the future or not. So you have, I guess, you have to be involved in what's happening, and so as to understand the next step. So it is not easy for us doctors to mention some things sometimes, because it is perceived as bad news, but it may not be bad news. It's just to be on the same page and to have the same information and share that. But you in the US and Canada probably do even more than we do at home.
On my
You're
end, I
right.
can.
Thank you. I've certainly learned that. Oh, sorry. Go ahead.
No problem. I just wanted to echo what Martha said. I feel the same thing. There is no standardized approach to precision medicine, and there is no precision medicine that the way we would like it, right? Starting with creatinine, continuing with DSA, and all these other biomarkers, none of them is perfect. And none of them should be necessarily alarming when you check it once and it's abnormal. It's that whole context of what patients are we talking about, what happened before, and what is the overall biological background that should determine a bit the next steps in a joint discussion with the physician and the patient. There's no magic to it, a lot of it at this stage is still being discovered, and the rest of it is patient and their physicians' discussions.
Thank you. I think there may have been one remaining question. What software or database do you use to calculate applet loads and mismatches?
Well, I can comment. There are lots of different ones, and it seems like the list continues to grow. The original software, if you want to call it software, it was developed by René de Quesnoy, and I think if you want to, that's the software that we have used in our original publications. And so if you want to reproduce exactly what we've shown, I think that's where a good place to start. Because that was developed many years ago and the people who've developed it are either retired or semi-retired, I think it's going to move out of favor just because nobody's working on it to continue fixing errors and adding new alleles and so forth. And so for that reason, some of the vendors have started to incorporate applet mismatch into their software. And I know some specific centers have also started to develop their own software. So the list continues to grow. And I think hopefully in the future, this will be part of vendor software so that when we get the HLA typing, we can immediately see what the molecular mismatch is without any extra steps. And we can lead the hard work of auditing the alleles and auditing the amino acids to the vendors.
This is one of my own questions. I open it up to the group. I've spent a lot of my my career thinking about de novo DSA and wanting to prevent that, and we've kept people at really high, a lot of immunosuppression, avoiding non-adherence. But the longer I've been around, I start to recognize that now our transplant patients are getting older. They have a lot of comorbidities and problems from that perspective. Are there patient groups that even if there's an applet mismatch, for example, that you are lowering immunosuppression? And how do you decide that?
Yeah, I totally agree with you, Carrie. I think that if you look at risk and age, for example, as I think what you're alluding to,
Mm-hmm.
as you get older, your risk of an alloimmune event seems to get lower, but that risk, at least in our own data, kind of plateaus and can even be slightly a J-shaped risk in the older patients, particularly over 60 or 65. And I can tell you from kind of peeking into that data that it seems like as you get older, your risk of viral infections also goes up. And then we end up lowering immunosuppression, and then we end up getting more alloimmune events like de novo DSA in those people. And so based on that observational data, I think anecdotally we've started to alter how aggressive we are with immunosuppression in the older people, regardless of their mismatch, with the belief that their immune system is just not as robust at that age, and so they probably don't need as much immunosuppression.
Yeah, we're starting to have that approach too, and thinking about patients who've had prior chemotherapy, for example. I think there's a real need for not only biomarkers to look for DSA or ABMR, but also what's their immune system like, particularly if you can't do an eplet match for everyone. Marta or Dr. Jamali, what are your thoughts about that?
We are very interested in of course, we are all very interested in trying to personalize immunosuppression, but we are dealing with older recipients each time. And because people are living more years, chronic renal disease is apparently more frequently, and then people get retransplanted. So the group or the proportion of all people or people over 65 or so is increasing. So there is a great debate, as Chris was saying, because sometimes they are going to be less reactive in terms of rejection, and they tend to have more infections. That's our feeling. Most of the problems derived from infections more than rejection, but we have to prove that, and not all are the same. So, but it's been very difficult. We've been trying for years to have trials on all people and to adjust immunosuppression, but we haven't had the funding enough to do that in Europe. So we don't have the specific data.
Yeah, I agree as well. And again, I think it gets back to the point that all DSA are not the same, and we still have the same issue and question to be determined by the eplet mismatching. I'm not sure the context with age, and I know that we have had young or old patients with tens of thousands of MFI values, but they are just doing fine. And on repeat biopsies, they have nothing, and we end up reducing immunosuppression because they develop infections. And at the elder age, I agree that if you can monitor using multimodality, at least for now, and closely monitor them, you have to do that personalized medicine again, not just consider the eplet or the DSA.
Excellent. I think we have just a couple of minutes left to close. May I invite each panelist just to share any kind of closing comments or put a finer point on anything that's already been discussed?
Well, I can comment. I think it's been a
Silence,
great
consensus.
session. I think,
Please.
can you hear me? Yeah. I was just going to echo one thing that was said earlier about enrolling your patients in trials. I think that's super important in antibody-mediated rejection. We don't have good therapies right now, and I agree with what was said that I don't think there's any point in throwing the book at patients with every possible immunosuppression. We should just do the standard of care, and if it doesn't work and they still meet the inclusion criteria for a trial, that's the time to enroll them, because I think the longer we try different things, often the GFR and the kidney function is going down and down and down, and pretty soon they don't meet the inclusion criteria for any trial. And so, yeah, I would just advocate that we definitely need better evidence for chronic ABMR treatments.
Anything else from our panelists?
I think this has been a great opportunity to learn about all this DSA treatment and molecular mismatch, and this shows that we are improving our knowledge. And with all the studies that we are performing, and especially the collaborative studies, we are learning a lot, and that's what we really need to learn all together.
Yeah, I want to also say the same thing. I learned a lot. It was a great session. We are in exciting times, although we are sounding maybe a bit negative, but we have a lot of tools coming on our way. We have clinical trials that are well designed, that are already in place, and new ones, as Chris was mentioning, are coming along. So we have the opportunity to make a difference as providers and researchers in the field. So I'm hopeful that in the next 10 years, we'll have some good answers to these questions.
Outstanding. Thank you. And on behalf of the patient population, that's fantastic to hear. Thank you so much. And thank you for all of the hard work. In particular, thank you to our session speakers for an absolutely enlightening and wonderful session. Next, you will see a link to the post-test survey on your screen. Be sure to complete the very brief questionnaire to receive your CME credit. I think next we will take a 30-minute break. Please take this time to visit the meeting sponsors in the exhibit hall. And after the break, be sure to join us at 1:45 p.m. Eastern Time for session 7, Success in Organ Allocation, Opportunities in Innovation. Thank you so much. Have a good day.